Hey, this is Joe Heiler from sportsrehabexpert.com, and I'm here today with Gray Cook at his Mountain River Physical Therapy Clinic, Gray Cook Sports Medicine. Just coming down to Chatham, Virginia to hang out and do some things with Gray, shoot some video. And one of the cool things, very cool things I got to see today was him working with a patient doing some trigger point dry needling.
Yep.
So we thought we'd take you through just some of the things that he did with that. You talk a little bit about the dry needling and then some of the progressions to follow. So Gray, go ahead and take it away.
First of all, Joe, I'm going to let you play the role of the patient. I'm not going to stick any needles in you, and you're not 60 years old and you don't have a total knee on left. But having said that, you're going to play the role of the patient. So
Sure.
Go ahead and lay down. And one of the things that we've been talking about all day, and I know you and I have discussed, is the fact that when I started doing dry needling, I had known about it for years because when I was doing my manual therapy certs up in Canada, many of the manual therapists told me that one of the best ways to manage soft tissue was with the trigger point dry needling. It's not acupuncture, but it is using acupuncture needles for more of a soft tissue or trigger point intramuscular manual therapy approach to give you a better definition. Now, I have a professional preference, and that's with the Kineticore group, simply because after a relationship with them and going through their level 1 and level 2 cert, they are one of the groups, or probably the only group, that looks at movement the way we look at movement. They've adopted our work, and I've definitely introduced them into my practice. I've got an entire station full of needles right now just because it's such a big soft tissue part of what I do. But there are many groups out there that are just simply following the good old-fashioned Travell trigger point referral pattern and needling out those muscles that are part of the referral pattern, but leaving all the dysfunctions on the table. So if you say my knee hurts, then they will needle all the muscles that could refer to your knee. But if you can't touch your toes, they won't connect the dots and say, wait a second, there's only a few muscles that can limit forward bending that also refer to the knee, and strategically take those off. So the SFMA alerts you to dysfunctional movement patterns that don't provoke pain, and also normal and abnormal movement patterns that do provoke pain. So now we take a powerful tool like the needle and introduce it both to correct movement and manage pain, and there are two totally different treatment sessions. I'm literally doing one thing to change your movement and not expecting it to reduce your pain. If it does, nice. The other thing I'm literally doing to reduce your pain, but I wouldn't necessarily expect it to change movement. This is a logical thought process and one of the best ways we've seen to manage patients when you're dealing with the multiple matrix of dysfunction. So here's what we had today. Joe comes in, he's visiting, I'm still caught up in treatment, total knee, got a golfer, barely can walk up a hill, 18 inches from a toe touch, severely restricted backward bend, poor single leg stance on this side. He talks about the referral pattern down through here, yet he's got a total knee. So I'm probably not assuming too much in saying that since all his articular surfaces have been removed, that the patient is having knee pain either from the local soft tissue areas here, since articular areas are removed and replaced, or referred from another area. Now, go online, find the referral patterns from the glute minimus, and watch that it has not only an anterior referral, but a posterior referral. It's got a huge role in hip stabilization, and it lies under the glute medius, and it can also medial and laterally rotate the hip. So I see it as a very close to the joint local stabilizer. We did some testing. Faber was uncomfortable. Forward bending was not painful but limited. So I'm going to use his dysfunctions to let me know I'm on the right track. So I positioned him here. I put a pillow between his knees. He was well prepared and informed about what dry needling was going to do. If I saw him in huge apprehension, there is absolutely no doubt in my mind that I might have done some laser work on the hip just to prep the tissue. But, you know, he was a well-managed patient, already seen before, so this is a good opportunity to dry needle. You saw me, I took a ballpoint pen. I marked the parameters of the iliac crest. I came in, hit the TFL, glute medius minimus, came in on the back and hit the piriformis and even got some glute max triggers. These were deep triggers and they were also first time triggers. They could have been present even prior to the total knee surgery, which is about 3 years ago for this guy. I hit them with a needle that was, I'm going to go ahead and open one up, and Andy, you can zoom in on this guy if you want. That's how long the needle was. Okay? So I'm burying that needle, and Joe actually came over and I had you piston the needle and actually tap on the ilium. So we were going all the way down through every one of the layers of tissue superior to the greater trochanter right there. So we were getting that much penetration into this hip ramus area. Now, as we did that, I was basically palpating with the needle, and I've seen Ado do this with Kineticore probably far better than I could, but I was palpating, getting the twitch response. Albert, assisting us, came in and did some stem down the shaft of the needle just to create some muscle contraction. You got to realize these ischemic trigger points probably hadn't had a normal contraction in years. So running that 1 pulse per second trigger point therapy with a point finder. This is a DC 9-volt battery driven point finder. Negative right here, positive right here, touching 2 poles in the needle, just stemming that thing, pulse, 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 pulse. Getting that muscle to fire was a big issue. But wanted to get that firing, so that was the next thing we did. And this probably took about 15 minutes. Needled out that hip. Why did I only focus here? I didn't want to focus anywhere else. I didn't want to treat out the knee. I didn't want to do anything else. What were some of the dysfunctional movements? Inability to perform single leg stance, inability to touch toes, easily 12 inches from a toe touch, inability to backward bend. Okay? Also, a lot of discomfort and inability to perform an active straight leg raise prior to 20 degrees, couldn't handle passive straight leg raise to 45 degrees. Needled out this, didn't touch the hamstring, didn't touch the low back, didn't touch the thigh. Immediately following that, and this is why we're doing this entire segment, there's magic in these needles, but it doesn't reset movement. This resets muscle tone. I need to create a situation that reinforces what I gained, and later on I want to reload a better pattern. Reset, reinforce, reload. We say this in all our workshops. If you don't have the capacity to reset tissue, that means change it without any active participation of the patient, then there's a good chance the exercises are not going to stick. Too many people introduce an exercise without creating a soft tissue reset, expecting sets and reps to change movement, and it won't. Think about how many dysfunctional movements they do in a day, and think about your 3 sets of 10. Who's going to win? It's not even a competition. So immediately after this, pull the guy's shorts up, roll to your back, sir. And this is exactly how we did it. We went down. This leg raise was 90 degrees prior to treatment. Active range of motion was here, passive range of motion was here. So the very first thing we did is I guided the motion, but I did not lift the leg. Lift as high as you can, and he went to about there. So we didn't not have normalcy, but we probably tripled active range of motion. Now here, this is a new pattern. So instead of letting him lower back down, what did I do? Push me back down. Good. I didn't want him to have any eccentric work at all. It's very new motion. Let's lift it up again. Let's take it down again. So think about what just happened. A concentric lift followed by a concentric lowering. Lift it up again and lower back down. Good. Now let's do some passive range of motion. Roll back up to your side. Now, all I did in this position, and pardon me for turning my back to you, is we allowed him in a different lumbar position to start exploring new motion. Once again, I'm not locking the knee. Drive your leg back down. We're exploring that side-lying leg raise, okay? Roll that ankle around. Do some fascial patterns right there. And he had definitely a positive dural stretch sign and a lot of gastroc soleus dysfunction. But notice, I'm getting this separation, but the lumbar is not in a vulnerable position. Many people who are reluctant to the active straight leg raise or have continuous sciatica really go hyperlordotic. We're just getting a lot of good motion here. Let that bend. A lot of good motion here. Now, after we made sure that leg raise was good, the very first thing I did with him is I didn't say pop tall. I lowered the table down and come on up and sit and plant your feet firmly on the ground. And I had the feet together first. And I said, do me a favor, just touch your toes a few times. Now this guy was a total knee patient. So posterior rock, which looks like this, which is a great way to open up that hip, that's not an option. He's probably not going to make it past 100 degrees. That's what I would do if I didn't have any contraindication to hip and knee flexion. That's not on the table. So too many people hear me talk, and when they see their patient can't do that quadruped diagonal, they just say, oh, I can't do great stuff, so it's done. Do that right there. Touch those toes. And I had him going like that. And then I said, widen your knees. So go out as wide as you can. Set those knees out even wider than your feet and point your feet straight and you just go straight down. Because the whole point is to stretch that low back and hip and learn to get down between those knees. So I had him repeat that pattern. But I also knew first thing in the morning, tomorrow morning, that ain't gonna happen. So I said, let's put a little stool right there. Can you at least make it to the stool? If you can, drive the stool through the ground. Now, what's gonna happen there? Maybe a little bit of a contraction with the adductors and the abdominals, but I'm also gonna get reciprocal inhibition to the extensors and abductors. Makes sense, right? So give me 4 presses right here. Press nice and hard, and you're aiming in the direction of your heels. So don't lift your heels up, but push your arms down. I want you to put weight on your heels and weight on your palms at the same time. Now, come back up and ease on down, and now you're not going to feel the need to put the brakes on. Nice. Now, if you can keep pushing the ground and bend those elbows and really try to get your shoulders between your knees, and breathe while you're doing it. Many people who haven't done this pattern in a while will actually inhale or hold their breath while they're doing it. Inhale on the way up, exhale on the way down. Good there. There you go. The next thing I did is I asked my patient to stand up. Joe witnessed all this, so we're not adding or taking away anything. And I said, touch your toes any way you want, not even with your feet together. And he went ahead down and explored range of motion. He got down near his toes, and then I said, come on up and bring your feet together. I'm not concerned if his knees bend or not, because we're breaking a habitual pattern, a pattern where he had no posterior weight shift in his forward bend. Now he's starting to get it. That means he doesn't mind loading his hips. When people don't posterior weight shift in the forward bend, you think it's hamstring tightness. The tight hamstring is keeping them from falling forward. They don't want to load their hips by setting the hips behind the center of mass. So hit the toes another time. And sure enough, this is a guy who was 12 inches off his toes. Now he's touching his toes. So now we've got a little buy-in. But my point is, this is a patient I'm only going to get to see one more time, and then he's going to go to the beach for a week's vacation. So his own exercise in this elaborate tubing drill, it's literally get out of bed, get this motion, get that motion, middle of the day, get that motion back. Now, one thing that happened here, and Joe saw this happen, all I focused on was his mobility. We tried to get symmetry in the active straight leg raise and turn that into a forward bend. With no stability work whatsoever, we got him nearly equal in single leg stance. And before, he had no single leg stance on left, and I said, put all your weight on this leg, lift the other foot, and then we got single leg stance. Now, Obviously, single leg stance is going to need to be trained, but anywhere he travels to is a doorway, and he can challenge himself in single leg stance. The default mechanism for somebody who doesn't trust their knee is to lock their knee and balance this way. If someone trusts their knee, they keep their knee soft and balance this way. So I told him, don't lock the knee, keep the knee slightly bent, and tap the door every time you feel like a balance loss, and work on single leg stance, but only after you've reset your leg raise, your toe touch, and your seated forward bend. This is real life therapy, and basically I'm going to get to see this guy maybe one more time, but he's got to make it through vacation. Once he's back from vacation, we'll work more on this. But my home exercise is no more elaborate than restore your toe touch and challenge your single leg stance. Shoot for symmetry. If you can go 35 seconds here, then stay here in this doorway for at least 3 minutes, working toward 35 seconds. The small degree of motor control that you gain will show in your gait. And this guy's got to walk around, shop a little bit, hit the beach, unstable surface, and maybe even play 9 holes of golf. This is real world therapy. And what I want you guys to know is, take a dry needling course, learn to manipulate soft tissue this way. There's nothing I could have done manually that could have got that deep in this guy's hip, okay? That laser will penetrate deep in the hip, but it will ready tissue. The reset happened because of the needle. But it's not just the needle. I didn't just stick a needle in this guy's hip and bring him up off the table. I reset his motion. I gave him something that he can reproduce, and hopefully he won't gain any greater motion, but he won't lose what we gain. That way I can build on my previous treatment's gain next time, and I won't lose it. That is the definition of reset, reinforce, reload. And I'm glad Joe got to be here for that, because many people think that I talk about these lofty technical theoretical terms, and that's not what I practice. I practice the SFMA, I practice the soft tissue and needling techniques I talk about, and my exercise is usually far less elaborate and far more practical than most people hold me credit for. So in the videos I show you lots of elaborate things with tubing, but real world is, I got a guy that needed to touch his toes and needed single leg stance, and that's what we shot for. So I'm glad you got to see that today, because
yeah, that was worth coming down just to see that. That was pretty impressive. Yeah.
But do me a favor, look that up. If you get a chance, get exposed to the Kineticore dry needling. There are other dry needling groups out there, but from a classic, good old evaluation soft treatment standpoint, I can't recommend them more highly. And I was very well educated in those techniques. I'm still learning. Ado, the director of the entire program, is going to be down here visiting next week. And as I learn dry needling, I try to impart what I know about assessment and corrective exercise. But it's definitely worth your time. But it's also worth not just doing the technique or the method, but then following that up with movement education, sensory awareness.